The nasal deformity consists of both skin and cartilage. The prolabium is wide and the columella is short. The skin-based repairs use this excess width and push it up to create a columella. The classic operation of this type is the banked fork flap operation. The prolabial flap is divided into 3 tines, which are split vertically. The lateral lip elements are brought down as discussed earlier in the video. The nasal floor is closed, and the lip closed at the height of the sulcus. Rather than discarding the lateral tines as described earlier in the banked fork flap method, an incision is made under the alar base and the forks are placed in whiskers position and saved for later use. The center of the lip is then closed as described earlier in this video. This is an example of one of Dr. Cutting's early banked fork flap operations. In the second stage, a bipedicle is made with incisions through the floor of the nose, extending into the nose. This allows the banked fork flaps to be advanced up to create a columella. Care must be taken not to overdo this. Here is one of Dr. Cutting's unbanking procedures, which often looks quite satisfactory on the table. The skin-based repairs tend to push the footplates of the medial crura up, making them worse in position as shown by this animated simulation. The second stage is done too early. Medial crus growth increases tip width rather than producing projection as shown in this growth simulation. We can see that the nose will become broader and flatter rather than projecting. Here is a typical result from this procedure done too early with a broad, flat tip. It should also be noted that there is no anterior nasal spine in these patients. The normal anterior nasal spine pictured here in Latham's work can be seen to be absent in the bilateral. This produces a cul-de-sac. If the medial crura are pushed up away from the cul-de-sac, the area retracts, producing a sharp scar band and a retracted columella at this site.